You are 43 years old, and you have spent the last 16 years building a reputation that exists in two places: the surgical wing of a university hospital in Bogota, in the quiet, private knowledge of every cardiothoracic colleague in Latin America who knows your name. You are not famous. You are something more valuable than famous. You are the surgeon people call when the case is too complex, the window too narrow, and the margin for error too small to risk on anyone else. You have operated on a sitting senator, a former general, and a child whose defect 3 other surgeons declined to touch. You do not lose patients you should save. This is your identity, your discipline, and the thing you have organized every hour of your professional life around. It is also, on a Thursday evening in November, the exact reason 4 men with covered faces walk into the ambulance bay of your hospital and tell the attending physician on duty that they need the best cardiac surgeon in the building immediately, and that the conversation ends there. They bring him in on a stretcher. He is unconscious, BP crashing, 2 gunshot wounds to the chest. 1 has nicked the pericardium, and the tamponade is building fast. You have maybe 20 minutes before the pressure kills him. One of the 4 men places a handgun on the instrument tray beside your prep station and tells you, without raising his voice, that if this man dies on your table, everyone in the operating room goes with him. He says it the way people say things they have already decided are true. You look at your scrub nurse, you look at your anesthesiologist, then you look at the patient, and your brain does what it has done in every critical situation for 16 years. It strips everything irrelevant away and focuses on the problem in front of it. You call for the pericardiocentesis kit. You begin. The operation takes 4 hours and 11 minutes. You repair the pericardial laceration, manage a secondary bleed from an intercostal vessel, and stabilize cardiac output to a level that will hold if he gets proper post-operative care. He lives. The 4 men are gone before you finish closing. There is no paperwork, there is no incident report. Your scrub nurse looks at you across the table when it is over, and neither of you says anything, because there is nothing to say that does not make the situation worse. 8 days later, a man you have never seen before is sitting in your car when you walk to the parking structure after your shift. He knows your daughter's school schedule. He knows your mortgage balance. He knows the name of the patient you lost 2 years ago to a complication you have never fully forgiven yourself for. And he mentions it the way someone mentions the weather, casually, without malice, which is the most frightening way it could possibly be mentioned. He tells you that the man you saved has requested you personally as his permanent surgical physician. He tells you what the compensation looks like. He tells you the alternative is not a conversation he is authorized to have. You sit in the driver's seat of your own car, and you understand with total clarity that the operation 8 days ago was not an emergency. It was an audition. You start the following Monday. What you enter is not chaos. That surprises you more than anything else about it. The facility is a converted private clinic 40 minutes outside the city, staffed with 3 nurses, a pharmacist, an anesthesiologist who you will later learn was recruited the same way you were, and a rotating security detail that is professional enough to stay out of your clinical space entirely. The equipment is current. The supply chain is reliable in ways that your hospital's procurement office has never managed to be. You have resources here that you have requested through legitimate channels for years and been denied. You notice this, and you notice yourself noticing it, and you file it under the category of things you cannot afford to examine too honestly. Your patient is a man the government of 3 countries is actively trying to locate. You know this because you read the news and because the security protocols around his care make his status obvious without anyone needing to state it directly. What you know clinically about him is that he has hypertrophic cardiomyopathy, a condition that was almost certainly the underlying factor that made the gunshot wounds as critical as they were, and that without ongoing management and possible future intervention, he is a significant surgical risk for the remainder of his life. This is what makes you indispensable, not just what you did in that operating room, what you will need to do again, and when, and whether you will be ready. You manage his condition for 14 months without a major incident. You adjust his medications quarterly based on echocardiogram findings you conduct yourself with equipment that cost more than your annual hospital salary. You monitor for arrhythmia, manage his exertion restrictions, and twice talk him out of activities that his security team has approved and that you have the authority to override on clinical grounds. He respects this. He is, in the clinical space, a cooperative patient, which you did not expect, and which makes everything harder in a way you cannot fully articulate. It is easier to do this if the person is a monster in every room. He is a monster in rooms you are not permitted to enter. In yours, he listens, he asks questions, and he follows your instructions. You have treated worse patients in legitimate settings. Then, in month 15, he presents with symptoms you concern significantly: exertional chest pain, a new murmur pattern, and an echocardiogram finding that suggests his left ventricular outflow tract obstruction has progressed faster than your most conservative projection. You run the numbers 3 times. The clinical picture is pointing toward a procedure, a septal myectomy, that is open heart surgery with a 4 to 6 hour operative window, a recovery period of 6 to 8 weeks during which he will be completely incapacitated, and a complication risk profile that, in a legitimate hospital setting with a full cardiac surgery team, runs at about 3% mortality. In this facility, with your anesthesiologist, your 3 nurses, and no perfusionist on staff, that number is different. You know what the number is. You also know that without the procedure, the progression of his condition puts him at serious risk of sudden cardiac death within 18 months. You request a perfusionist. The coordinator tells you it will take 3 weeks to arrange someone with the right profile, meaning someone who can be brought into this structure safely. You tell him you need the right equipment as well, that a bypass surgery without a properly calibrated heart-lung machine is not a surgery you will perform. He tells you it will be arranged. You spend 3 weeks doing what surgeons do when they are preparing for the hardest case of their career. You review every piece of literature on septal myectomy outcomes, you run procedural simulations in your head at night, and you try not to think about the fact that if something goes wrong on that table, there is no transfer protocol, no backup team, and no version of this where you call for help from outside these walls. The perfusionist arrives on Wednesday. He is competent. You assess that within the first hour of working with him. The equipment is correct. Your anesthesiologist has reviewed the case and has no procedural objections. Everything that can be prepared has been prepared. The surgery is scheduled for Friday morning. On Thursday night, you sit alone in the on-call room they have assigned you inside the facility, and you do the thing you have been avoiding for 14 months. You think about what it means that you are here. Not the coercion that brought you, which is real and which you have never pretended otherwise, but what it means that you are still here, that you have become good at being here, that you have optimized your clinical work inside this structure with the same discipline and precision you brought to every legitimate posting in your career. You tell yourself you had no choice at the beginning. You are no longer certain that fully explains the present. Tomorrow, you will open his chest. You will stop his heart, you will repair the obstruction that is killing him, and you will restart the heart, and you will close, and he will, if everything goes correctly, have years ahead of him that he would not otherwise have had. Years in which he will continue to be exactly what he is in every room you are not permitted to enter. You are the best cardiac surgeon in the building. You have always known what that means when it saves the right person. You are still working out what it means when it saves the wrong one. If your hands are the reason a dangerous man stays alive, does the oath you took protect you, or does it implicate you?